today's topic is palliative care in non-cancer illnesses. So as we all know, the word palliative is derived from the verb to palliate, means to improve the quality of. According to the Merriam-Webster dictionary, it means to reduce the violence of a disease or to ease symptoms without curing the underlying disease. It is derived from the Latin root to palliare, means to cloak. I think that the word pallu must have originated from palliare. You know how a mother would cloak her child in her sari ka pallu with affection and care. That's what it means. As we all practice Western healthcare, we know it firsthand that it is aimed at investigating, diagnosing, prolonging life, curing. We all take pride in accomplishing each and every task in this list. This way of thinking does not ask us to look into the quality of life or the suffering or the ultimate endpoint, death. We avoid talking about death. But some people were brave enough to think about health-related suffering, death, and dying. They formed the galaxy of stars who give us guiding light. The first one is a great person named Dame Cicely Saunders from Great Britain. And the second one is Dr. Balfour Mount from Canada. And of course, Hippocrates is our North Star, Dhruva Tara. The teachings of Hippocrates should always be at the background in our mind, should be ingrained in our conscience. Hippocrates taught us two important principles. We all know them. Do no harm. That is the first principle, do no harm. And the second one is a corollary of this. Do not limit life willfully. In my opinion, not educating a patient or the family about a disease or letting a patient undergo an unnecessary procedure is harming a patient. If we follow this principle of not doing harm, we shall automatically follow the second principle as well. These two principles are embedded in the ethics of palliative care. Now, Dame Cicely Saunders. We all should read about her career. It is very inspiring. She revolutionized the way in which society cares for the ill, the dying, and the bereaved. She told us to look at the patient and family as one unit and pioneered a fundamental principle of palliative care, the concept of total pain. Remember this for the students specifically, total pain, that encapsulates not only physical pain, but the emotional, social, and spiritual dimensions of pain as well. The third star of the galaxy is Dr. Balfour Mount, who is considered the father of palliative care in North America. He started the first palliative care service in 1970s in Canada, and he is the one who coined the term palliative care. So this is the history. Now, what is palliative care? How is it defined? Now, there are many definitions put forth by prominent organizations like WHO. All of them may differ in wording, but they all carry the same message as follows. The palliative care is an interdisciplinary medical service. This is very important. Palliative care is not practiced by one clinician, one medical provider in a silo, but it is all interconnected. So whoever is working on a palliative care patient, they always talk to each other and they figure out a plan. That's what it means. It is provided at any stage of a serious illness. And I will tell you the definition of a serious illness shortly. Palliative care improves the quality of life of patients and their families, not only that of patients, because we always focus on patients and we forget about the families. So palliative care teaches us to focus on families as well. How do we do that? Through anticipating, preventing, and managing health-related suffering. For example, a person with a neurological disorder may have dysphagia. We can anticipate that, based on our knowledge of the disease and experience. We can educate the caregiver or the patient himself that this may happen, and we can prevent it to a certain degree by changing the consistency of the diet And lastly, we can manage it by training the caregivers appropriately, such as having suctioning by the side of the patient's bed and things like that. So please note that the word cure is not included anywhere in this definition. The last one is facilitating patient autonomy. So in the literature, it says that when autonomy is given to an Asian person, especially an Asian woman, it means that you are isolating that patient from his or her, from her family. So autonomy is a big deal in USA, but in Asia, things may be different. And I will let you ponder over it. You may know more about this than I do because I have never practiced in India. Access to information is very important everywhere in the world these days, and this includes access to internet and having access to their own medical charts for the patient. And choice. Choice is of utmost importance in palliative care. The choice of saying yes or no to the treatment being offered. So you cannot just go ahead and give chemotherapy or just put patient on ventilator, put a tracheostomy in the patient's throat without asking the patient's permission. So this is very important. We need to learn this. And addressing personhood. Palliative care addresses personhood. So when I did my fellowship, I learned this new beautiful word, personhood. So we are just like this rangoli, if I might say. We have layers to our existence. We are not just physical bodies, but we have thoughts and emotions. We have social attachments, and we have spiritual needs. Spirituality is a vague word, mystic word. Spirituality is about the meaning and purpose of life. So what is a serious illness? We use this word rather lightly, such as, oh, have a serious cold. But much is talked about serious illnesses in the literature rather seriously. So an illness that carries the risk of mortality and either negatively impacts a person's daily function or quality of life, or excessively strains the caregivers because the patient is not able to do any of his activities of daily living. It's called ADLs. We shorten the activities of daily living to ADLs. Which are the serious illnesses? We know them all. Look at this list. Cancer occupies a very small portion of this list, a fraction of the space. As per the conceptual definition above that I just told you, all of these diseases, they increase the risk of mortality. Not only that, but they affect the quality of life adversely, that of the patients and their families as well. These patients are not able to do ADLs, and their healthcare utilization is high, raising the eyebrows of the hospital administrators and Medicare in USA. This list is not exhaustive, it's not a complete list. Long-term consequences of diabetes, those of autoimmune diseases, and now the sequelae of COVID-19 infection, they also fall into this category. All of these illnesses that I just talked about, though placed under the category of serious illnesses, they have totally different trajectories. They are conceptually similar, but they behave differently. I have used this graph to educate patients and their families about their diseases. The first one is that of sudden death. So now when to call a palliative care consult in the hospital or as an outpatient is a dilemma to some physicians. So let us look at these disease trajectories and let us decide when to call the palliative care consult. So in the first trajectory of sudden death, the patient is gone. I mean, why do we need palliative care consult, right? But remember, the definition of palliative care, it includes the families as well. It is the service given to the patient and their families as well. So for example, our palliative care team was consulted on a 49-year-old patient who had cardiac arrest at home in US. And now he was brain dead on a ventilator for 2 weeks after so-called successful resuscitation, initially by the paramedics, because they call 911, the family called 911. Our palliative care team held meetings with patient's family 3 days in a row, several hour-long meetings at a time, answered all the questions, made sure that the family understands that there will be no meaningful recovery going forward from this point. Finally, patient's mother and wife both agreed on discontinuing the life support. It was very sad. Patient passed away peacefully in ICU right after extubation. One thing we did for the patient and family was enrolling the patient on hospice services when he was on the ventilator. And the family continued to get bereavement support from that hospice throughout the year, which was much needed because of the sudden death, because they were in shock for a long time. Yeah. So that is about sudden death. So palliative care team should be consulted right away. Secondly, in cancer patient. Now, we all know palliative care is called in cancer patient, but when? Okay. So I'm talking about metastatic cancer. Palliative care should be consulted as soon as the diagnosis is made, so that the team, palliative care team, makes rapport with the patient and family. They can do advanced care planning. They can prepare the patient and family for the anticipated complications, ICU admissions, side effects of chemo, etc. Because it's a long-term relationship. Consulting palliative team when patient is going downhill here at this point is not conducive to a good long-term relationship that a palliative care team should have. Same thing is true about the neurological diseases. The palliative care team should be consulted on the day of diagnosis. Now, the trajectory of dementia is slow and vague. Patient doesn't become ill as such, so at such in the beginning. This disease demands lot of time from the caregivers and the clinicians as well. The goals continue to change as the disease evolves. So we'll talk about the advanced care planning later. The most confusing trajectory is that of the organ failure diseases. So COPD, the chronic lung disease, CHF, congestive heart failure, end-stage renal disease, end-stage liver disease, they all fall into this category. And it's very confusing. They occupy a substantial space in the list of serious illnesses. So for example, a patient with congestive heart failure who ends up in the hospital at the bottom of this trough, okay, he starts walking around without oxygen after adequate diuresis. So he reaches this point, and patients and family think that, well, he's good. They go home without thinking much about it. And only to find this patient back in the hospital at this step within few weeks. So I took care of such a patient on palliative care for 1.5 years. Before that he came on palliative care, he had 6 admissions in 3 months. Finally, it dawned on the cardiologist to call the palliative care team. Patient was managed at home with regular visits from a palliative care trained nurse and a social worker, and of course a physician. Patient did not need a single admission to the hospital, even to the ER for almost an year. I'm proud to say that. He enjoyed his life with his family. He took his regular medications, saw his cardiologist as an outpatient and other doctors as well. But naturally, he slowly declined and qualified for hospice care due to dyspnea at rest. And about 4 months later, he passed away peacefully at home with his family at bedside. We strive to repeat such success stories irrespective of patient's diagnosis and prognosis in palliative care. So what are the myths about palliative care? And you will be facing it if you are practicing palliative care. Even if you are not practicing palliative care as a specialized physician, you will face this question, and I want you to know these answers. I have been asked that, oh, palliative care, that means euthanasia, that means mercy killing. I said, no, it is not. Is it end of life care? Palliative care, is it end of life care? This confusion arose from the fact that the concept of palliative care originated from the hospice concept itself. Palliative care delivered at the end of life is hospice care. So end of life is defined as lifespan certified to be less than 6 months duration. Non-hospice palliative care is provided throughout the course of a chronic serious illness. So that there is a much difference in end of life palliative care and palliative care given for years together. Okay. It is an attempt to contain medical costs. Especially in US, in my hospital, I was asked that, oh, because the hospital administrative staff, they want to cut down the cost, and that's why they want to have this patient to be on palliative care. Not at all. Suppose a chronically ill patient, he or she is offered dialysis, okay? So the choice is given to the patient. It is their prerogative whether to accept it or refuse it. So it is not that they are not offered the usual treatments or therapies. No, everything is offered to them if they are on palliative care. Rest of the statements rather are self-explanatory. Does it hasten death? Does palliative care hasten death? Of course not. Studies have shown that patients with non-small cell lung cancer lived 2.7 months longer when they were on palliative care as opposed to the group who was not on palliative care. So this is very important, and this you should tell your patients and other medical providers who have some doubt about palliative care in their minds. Choosing palliative care, does it mean that do everything or versus giving up everything? No, the disease-directed therapies, chemotherapy or BiPAP at home, or whatever the patient taking for multiple sclerosis, it is all continued along with the palliative care. So palliative care is an extra layer of support given to the acute care. So we need to remember that. What are the benefits of palliative care? Why should we choose palliative care? The most important thing, the first and the most important thing is family satisfaction. What is satisfaction? How do we define it? Can we define satisfaction? It is exactly opposite to disappointment, if you will. If the family is well prepared about the trajectory of the illnesses that I showed you, their expectations and the available medical care are aligned well, then there is no confusion. And even if the outcome is sad, even if patient declines and passes away, it becomes a relatively smooth ride in their minds for the patient's families. And this decreases the stress, this decreases the medical legal liability for the clinician. So remember that. It reduces the readmission rate. So I talked about it, especially in the end organ failures. Then it reduces ICU utilization. Certain patients should never end up in ICU, such as patients with advanced dementia, patients with advanced cancer when no treatment is available, and bedridden patients with poor quality of life from any diagnosis. Hence, the immense importance of discussing advanced care planning. Physician burnout. We talk a lot about physician burnout in US, and especially during the COVID days, we talked about it a lot. Palliative care team talks to the referring doctors first. They just don't go and see the patient, okay? They first study the chart, talk to the referring doctors. The referring doctors get a chance to unload their concerns, annoyances, frustrations, and get catharsis out of it. So discussion of a complicated chronic patient with our colleagues is as good as a bench therapy in psychiatry. So this is very important for the physicians as well. Caregiver burnout. I urge you to do one thing for me. Please, always, always, always compliment the caregivers for the job they are doing in taking care of a chronically ill patient, even if they are getting paid. Try to understand how much they are sacrificing for the patient, and try to find respite for them. This growing unpaid workforce, which are mostly the women in the family, this growing workforce is generally invisible. They are not trained, and they are stressed physically, emotionally, and financially. Palliative care team is a big help to them, especially the social worker in the palliative care team help them a lot. These caregivers will be grateful to you if you give them relief from their duties, even for a day. What are the functions of a palliative care physician? As you must have gathered by now, communication, communication, and communication. Communication with the patient, communication with patient's family, and communication with the colleagues, the other referring doctors. The most important exercise that the palliative care doctor would do with the patient and the patient's families is doing or going over the advanced care planning. If you engage your patient in ACP, advanced care planning, then you are fulfilling more than half of your duties in basic palliative care. Rest of the things will follow, such as pain management, family caregiver support, reconciliation of medications. So what is advanced care planning? This is the second most important slide in my webinar, in my presentation. Advanced care planning, as I told you, it is the basic palliative care core competence for all the clinicians. And it is recommended, and listen to this carefully, recommended to start in early adulthood, regardless of health status. So patient comes to see you just for a common cold or little health ailments, but you get a chance to talk to them about advanced care planning. And why should we do it? Because the life is unpredictable. I have prepared my own living will. I have done my own advanced care planning, and I have asked my children to do one for themselves as well. So in clinical setting, when should ACP be discussed? When should advanced care planning be discussed? When the diagnosis of serious illness is made. So in case of dementia, even if dementia is diagnosed in its mild state, hopefully it gets diagnosed in the early stage, ACP should be discussed right away. It does not upset the patient, because people don't like to talk about death and end of life issues at all. So we think that it will upset the patient, it will upset the families, they will not come back to you. That is not the case. Actually, it strengthens them, okay? It makes them more aware of the disease process or even the life as such, and brings family members together in decision making. When there is disease progression, so if a patient with multiple sclerosis has new symptoms, or patient with dementia has aspiration pneumonia, you take that chance to discuss the ACP. Functional decline. So an ALS patient becomes wheelchair bound. You discuss ACP. Poor quality of life, it is straightforward. Patient is bed bound, has bed sores, etc. Or patient has limited prognosis. Patient is diagnosed with metastatic small cell lung cancer. So if you or the family member sense that patient is not doing well and may not survive for the next year, then discuss advanced care planning by all means, irrespective of the diagnosis. And transitions in care settings. So this happens a lot in US hospitals, that patient comes to the hospital from home and patient has such complicated problems and he has declined so much that he or she cannot go home anymore. Families cannot take care of this patient. So patient is being discharged to a nursing home because needing more nursing care, or a group home, or to inpatient hospice unit. And that is the point, again, advanced care planning should be discussed. What do we discuss as advanced care planning? The first point is that of discussing risks, benefits, and limitations of the disease-directed therapy. So remember, patient is still getting acute care on one side, and he comes to see you as a palliative care physician. So you are going to make sure that patient knows the diagnosis, okay? That is very important. Patient knows what medical treatments he or she is taking. When you are discussing the side effects of the treatment or therapies, do not use medical jargon. You will get, like, I have heard doctors talking to the patients like, you will get stomatitis, alopecia, and neuropathy. No, this is not how it should be explained. Instead, we should say that in clear language. You may get sores in your mouth, your hair will start falling, and you may fall too because of neuropathy. Again, the graph of the disease trajectories comes in handy to educate the patient. So we always keep a laminated card of that disease trajectories in our pockets when discussing advanced care planning. So one study showed that 40% of patients getting chemotherapy for advanced colon cancer did not know that the toxic treatment they are getting is not curative, but just keeping the cancer at bay. They were very upset. Most of them said that they wouldn't have tried it if they had known this, because the chemotherapy was extremely toxic. So hence we should discuss the risk and benefits of the treatment. Starting, maintaining, withholding or withdrawing therapies, extremely important in today's high-tech world. Okay, think about a patient on prolonged mechanical ventilation due to COVID pneumonia. Each day in ICU, each day that patient spends in ICU, it decreases the chances of meaningful recovery. If patient is 100%, 100% FiO2 and remains on mechanical ventilation for weeks together, then the dismal picture is clear to the clinicians and the truth be told to the family at the earliest. Otherwise, the Hippocratic oath of doing no harm is violated. I consider the practice of medicine as being sacred, and doing such things is bad karma. So we all know that. Transitioning to end of life care and hospice, patient and family will be grateful to you if you define the state that patient has reached, needing comfort care rather than aggressive, pointless ICU care. So this is what advanced care planning is all about. I hope I made it clear to you. If you have any questions later, let me know. So within the realm of non-cancer illnesses, dementia is considered as a looming pandemic. Prevalence of dementia in India is up to 10.6%, with variations across different states. So some states have only 0.8% prevalence. Some states like Himachal Pradesh has zero prevalence. So 10.6 is a general figure quoted for this purpose. The prevalence will rise with increasing aging population, and we know that. Who is it that can tell me who I am? This is King Lear asking. This is actor Sir Laurence Olivier. We are all afraid to reach this stage in our lives. We can only hope that at such vulnerable times, we are surrounded by kind and compassionate people. Now let us hear a testimonial from a loving son who took care of his mother very well with dementia until the end. This is Dr. R.G. Kulkarni from Sangli.
I never thought I would have to make any difficult decisions for my mother. She has been healthy all her life. We are two siblings. We never talked about the possibility of any illnesses at the end of her life. Talking about her death did not suit any occasion when she was still alive. When she was diagnosed with dementia, we did some reading on our own. We discussed with her doctors, especially her neurologist, but we were not prepared to deal with the last few years and especially the last few months of her life engulfed by dementia. In the initial stages of dementia, it was easier to take care of her. She was mostly forgetful, was not able to take care of her financial affairs. She stopped cooking. Later, hygiene became an issue. Then she started falling. We had to make the whole house secure for her, like one would take it for a child. The worst part was she became incontinent of bladder and bowel. Keeping our house clean became a never-ending task for us because she was still able to walk around in the house. I talked to a palliative care doctor from US because palliative care was not available in our town and it is still not available here. The palliative care doctor suggested two very important things. One is how to control her agitation. Secondly, if all the siblings agree, treat her at home only and not to admit her in a hospital. That gave us a plan of action and orientation to the end of life issues. One day, she had fever. Her doctor gave her antibiotics at home. She slowly declined. It gave us time to call our close family. She passed away peacefully when her children were around her, in her own house, in her own bed. When we look back, we are thankful that we had the courage not to hospitalize her. I wish that she had palliative care services from the very beginning. It would have helped us understand her disease better. Plan ahead of time and reduce the stress on our families. Thank you.
Thank you, Dr. Kulkarni, for sharing this rough part in your life. He told us the story of dementia in nutshell. I hope you listened to it carefully. So he was asking us to do advanced care planning as well, and how important it was to him and his family. So advanced care planning is of paramount importance in dementia, given its vague nature and prolonged trajectory. This needs to be discussed every year to see if patient's clinical status has changed or his or her perspective towards life has changed. The ACP in dementia, advanced care planning in dementia, includes, I have only put certain important points. There is a long list of things that can be done under advanced care planning. The most important thing we can do is documenting patient's wishes by getting a living will done on paper and signed by the patient. And the wishes are regarding about aggressive healthcare, what ifs. So what if you get a heart attack? What if you need dialysis? What if you need surgeries, elective surgeries, that is? What if you go into cardiac arrest? Do you want to be revived? All these what ifs are discussed in that document. It's a living will. And again, this can be changed again and again as the disease progresses. So that this is very important. Second one is designating a medical power of attorney. Very, very important in US. The patient chooses a person who knows him well, who knows patient wishes well. And this person will make decisions when patient himself or herself cannot make those decisions at a critical point in time. Now, the goals of this exercise are to avoid unnecessary treatments and procedures, and to be able to transition to hospice care and keep patient comfortable when the time is right. And when is the time right? Meaning when patient reaches stage 7A on FAST scale. And this is another laminated card. We keep it in our pocket and we share it with the families. So what it tells us is the progression of functional decline and cognitive decline as well to a certain degree in a patient with dementia. So as per the Medicare rules, if the patient reaches number 7 on the scale, we can consider hospice care. To tell you the truth, if the patient is at 6E, where it says, I don't know if you can see this, moderately severe dementia, patient starts having fecal incontinence. This is a very miserable stage in anybody's life, horrible. So what if patient has another ongoing illness like congestive heart failure, kidney failure? So we put them together and we try to give patient hospice services because it helps patient a lot. So think about that. So what is hospice care? Even essentially it means conservative care. So try to focus on patient's comfort rather than, as I told you in the past, investigating and prolonging patient's life and things like that. So this scale is very important. It's a great objective tool to grade the plight of dementia. A patient with dementia declines to an infant-like state, which falls in this section. This is an infant-like state, but it's not cheerful or delightful like an infant would be. This is a harsh reality. This is the end stage dementia, which could be heart-wrenching. Dignity is lost due to the need for very private personal care. The ability to eat becomes compromised and the patient becomes bedbound, needing total care. This is when comfort care is appropriate. And when you spend enough time over this particular domain of palliative care, that is advanced care planning, you will be saving patient and the family from facing medical poverty, because this is when in this stage patients end up in the hospital, patients end up in ICU, they're at high risk for getting sepsis. So in this age, if you keep the patient at home, keep them comfortable, let them pass peacefully, the families will be very grateful to you. And that is the duty of a physician, especially that of a palliative care physician. So I hope I made my point clear in this regard as well, and we can talk more about it later. So do no harm. As we know, this is the first principle of ethics. Avoid unnecessary interventions. Which are those interventions? feeding tubes. So when patients become bedbound, they are not able to eat. That is the natural decline in dementia. And Mother Nature is saying that, okay, we are closing the chapter here. If we don't go with that plan, and the families want patient to eat and have food in their body, that becomes a big deal. And this is a matter of contention between the physician and the family. So we really need to prepare ourselves how to discuss this matter. Hospital transfers, ICU admission, I talked about it. IV therapies, the patients are very much for it. They think that IVs will cure anything. That my father should get IVs because he's not eating and drinking. That IV does not help the patient. Actually, it prolongs the misery of the patient, and the fluid can go onto their lungs and cause shortness of breath and things like that. That needs to be explained to the patient's family and avoid it at any length. Labs and lab draws and x-rays, they become burdensome rather than being beneficial. So avoid them at any cost. Now, when you are entering a room to discuss the advanced care planning, these conversations are rather heavy, very serious discussions. They can take a toll on the physicians, especially if you're new to palliative care. Always be smiling, always use appropriate jokes at the beginning of the conversation to break the ice. And I use this joke. So Bob Hope, who was a well-known American comedian, he was once asked, "Do you want to be cremated or buried after your death?" He scratched his head for a second and said, "Surprise me." And this puts a smile on everybody's face, including the nurses and social workers, and it relaxes the tension in the room, and further talks become much more easier. Of course, you will have to find your own culturally appropriate joke. Um, so I have created this website for patients with dementia. We can talk about it later. Music and art therapy in dementia have been shown to decrease anxiety and need for pain medication, need for medication for agitation. So we'll talk about it later. I can talk all day long on this topic, but knowing is not enough. We must apply this information to the current situation. Then only it will become knowledge, and willing is not enough. We must do it. So good or Gete. He's the German Ramdas Swami, if you will, because what he's saying is, "Kelyane hotya here adi kele chipahije," as we say in Marathi. So we must mend the hole in the fabric of the medical care in India. So the purpose of this webinar is to urge the medical community to embed this patient-centered, compassionate discipline in your everyday practice. Every clinician can get himself or herself trained in basic palliative care. Pallium India and Indian Association of Palliative Care offer online and in-person courses. There are insufficient numbers of palliative care physicians in India to meet the needs of patients living with chronic serious illnesses. Hence, all clinicians should receive training in basic palliative care. Hope you all join this activism with us and help get palliative care ingrained in the fabric of medical care in India. I would like to end my speech with the impressive words of Shakespeare from his magnificent play, King Lear. If you haven't watched it yet, please do so on YouTube and only watch Sir Laurence Olivier's play. And it's a movie, of course. One of the courtiers of the king says, "O king, let me kiss thy hand." And King Lear says, "Let me wash it because it smells of mortality." Only Shakespeare can write like that. As a matter of fact, the smell of mortality surrounds all of us. Let us change that smell into perfume by supporting palliative care. Dr. Rajgopal himself is a role model for all of us. He used to be an anesthesiologist, but now he teaches and practices palliative care. I will request him to talk about Pallium's work in this regard and guide us further. Thank you very much for listening. Let me know if you have any questions.
Everybody, good evening and good morning, Bhagya. Privilege. Thank you very much for organizing this. For a moment, before I share my screen, I would like a bit of a few seconds for reflection. I don't know how many of you listening today is able to think about your own mortality. It is harder for young people. Sometimes it's hard even for the elderly. But I must also say that it's a great strength to be able to think of ourselves as mortal beings. In Bhutan, they have a custom. Everybody has to think about one's own death 5 times a day. Oh my good God, how morbid you might think. But remember, till recently, till Western civilization invaded them, they came first in the world on Global Happiness Index. They are not the richest. Their GDP is way down. But they came first on Global Happiness Index. Being aware of one's own mortality, the thorough knowledge that I'll die someday makes me value life, makes me spend my life meaningfully. Why am I saying that? As an extension to that, being able to think about illness also in our own case enables us to treat others the way we would like to be treated ourselves. Unfortunately, we will all die someday. Only 10% of us will be blessed with a sudden death. Many people say, oh, I just do not want to be dependent on others. I'm sorry, 90% chance is that you will have some time when you will be dependent on others. That's a reality we have to face. Now, if we remember that, we will then be able to treat people, especially those with suffering, a bit better. Your medical education and mine, my medical education more than half a century back, and your medical education has been concentrated almost exclusively on diseases. All basic sciences so that we understand the organs, the body, not the person. Bhagya earlier talked about personhood. Nobody taught us about treating people as a persons. We were concerned with bodies and organs and diseases and curative treatment. Unfortunately, there comes a time in everyone's life, for most of us it will come later, for many it will come early, when we suffer illnesses ourselves. And unfortunately, the doctors around us will treat our organs, will treat our chemistry. As soon as the sodium drops, you will get hypertonic saline going into you, forgetting that hyponatremia can also be a terminal event. It is a sign of failure of the sodium-potassium pump. It can be caused by reversible problems, in which case it needs to be treated with hypertonic saline, but even irreversible, as in a terminal illness, as Bhagya already said, it only adds to the problem. So we will remember all that and remember the personhood that Bhagya talked about. It was an Australian psychiatrist, Eric Castle, who said, it is persons who suffer, not bodies. And here we are going to talk about suffering and relief of suffering. Let me share my screen and remind you of the duty of the healthcare provider, your duty and mine. This is how Indian Council of Medical Research, we don't have a law covering this, unlike in the UK or somewhere. We don't have any law saying what's the duty of the healthcare provider. Here is it. The duty of the healthcare provider is to mitigate suffering. That's the first sentence. I have given the reference here. Anybody can have this presentation. The duty of the healthcare provider is to mitigate suffering. It is to cure sometimes, to relieve often, and to comfort always. That's an aphorism borrowed from 14th century. And remember the last two lines. There exists no exception to this rule. There exists no exception to the rule that you and I, as healthcare providers, have a duty to mitigate suffering. Mitigation would be preventing and treating suffering. And that's precisely what we were not taught in MBBS or even in our MD or DM or whatever degrees we have accumulated. This has not been taught. This session was titled for non-cancer illness. And here comes the relevance. This is from a fairly recent document. 2018 Lancet Commission report, 2017 Lancet Commission report on access to palliative care and pain relief. Only about 22%, 20% here and 2% coming among childhood cancers. Of all people who need palliative care, only about 22% have cancer. The largest number globally is HIV. Oh, in India, I know this will be much less than this, but still. There will be a substantial number of people with all neurological diseases and a substantial with dementia. Substantial number with respiratory diseases too. Imagine somebody with COPD. What will their end be like? The breathlessness, the air hunger, the desperate attempt to take a breath. And how would we treat that? Pushing a tube through the trachea? Would that add to the suffering or would that relieve the suffering? The friends, when I appeared for my MD examination such a long time back, the examiner asked me, tell me one contraindication for morphine. I said dyspnea. And the examiner said, good. That answer was correct as we believed at that time. Today, morphine becomes the drug of choice in respiratory, in terminal breathlessness, including in COPD. You think it will kill people? Not at the dose that is recommended. Not at a dose of 2.5 to 5 milligrams 6 hourly, or a bit more if the person is also on pain. One of my professors died 7 days back of advanced cancer. His wife had died 1.5 months back of advanced cancer. Both of them had severe breathlessness. Her daughter, a doctor in the United States, was helping with the management from a distance, and we were looking after them. Both of them were put on morphine. In her case, the day after I saw her first, when I saw that she was getting 3 liters of oxygen inhalation per minute, I started morphine, and over the next 3 days, her oxygen was discontinued. With that small dose morphine, the breathing becomes easier. When it is easier, as every anesthesiologist here will know, gradually the breathing becomes slower, not abysmally slower. The desperate attempt to take in more air is there stops, and therefore the breathing becomes more even. Air passes through the airways easier, and her oxygenation improved. So this is the way What I was not taught during MBBS or MD, and what I learned later in palliative care helps people in suffering to live well with disease, and eventually, when the time comes, to die well. But unfortunately, though Indian palliative care is 35-year-old, it took birth in Maharashtra as Shanti Avedana Southern in Mumbai, created by Dr. Lucito D'Souza 35 years back. And after all these 35 years of efforts, still access to palliative care is more than 4%. Hence, ladies and gentlemen, this meeting fills me with hope, where people from Indian Medical Association, Indian Society of Anesthetists, all get together and discuss ways of relieving that suffering. That's the first global error of omission of healthcare system that I'll mention. That about 10 million or close to that people in India with serious health-related suffering do not get relief. They die in pain and agony. That's so for 96%. And then you can imagine the plight of vulnerable population. Even in Kerala, where generally the status of the woman is better, we find that male patients outnumber female patients. In the population, we have 53% women. But in the patient population, we have only 46% of women. They get healthcare less. Children, people at the extremes of age get healthcare less. We don't even have to talk about people with disabilities. They live and die within 4 walls. People with different sexual orientation, like LGBTQI population, prisoners, geographically isolated people, tribal population, my God, we leave them in agony with practically no health care. So why am I saying all these bad things? Here are problems that we could solve at low cost. Today, leave alone those errors of omission, we cause 2 errors of commission. India is among one of the worst 12 countries globally, where catastrophic health expenditure is worst. In India, it is 55 million a year. It's growing every year. The figure that we have now is 55 million. More than 4% of our population is destroyed by the growing catastrophic health expenditure. And more than 29,000 people in India kill themselves for health-related reasons. Dr. Sankhamitra is a British oncologist of Indian origin for whom I have great respect. He now works in Australia. He and his wife work. The family lives on his wife's earnings, and all his earnings come to India for providing cancer care and palliative care in the northeast of India. And he says, in India, the poor die in misery of neglect. The middle class die in misery of ignorance. The rich have the worst kind of deaths. They die on ventilators, alone, hands and feet tied up. No one gets a pain-free and dignified death. Friends, this is a situation that we are going to change. The National Cancer Grid is a conglomeration of more than 300 cancer institutions in the country. And together they declare, do not treat patients with advanced metastatic cancer in the intensive care unit unless there is an acutely reversible event. But you and I know what happens even in those 300 centers. In the majority of those centers, only a minority have implemented this. So, friends, what can we do? for every patient that we treat, whether it be anesthetic practice or something else. Let us not go by the old concept which is long buried, that palliative care is only for incurable people. Palliative care people goes hand in hands with disease-specific treatment. Whatever be the disease. If there is suffering, okay, if it is cancer, chemotherapy or radiotherapy is started or surgery. But along with that, we relieve suffering. And with the death of the patient, palliative care does not end. As Bhagya said, palliative care is also for the family. They are in intense suffering. It continues as support for the bereaved. Let me take a minute. If earlier we recommended that people with advanced cancer or advanced other diseases, people dying of COPD, for example, should not be treated in the ICU. So how will they be treated if they are intensely breathless? Coming to your emergency room, breathing like that, what would you do? I'll explain what we do. We will not isolate them. Tomorrow it could be me. The one thing that I would want is to have my family by my side. Maybe to hang on to my son's hand when I'm scared. We will not isolate them. If they are indeed terminally ill, we will give oxygen. But you and I know that equilibration between inspired air and arterial blood takes only 7 minutes at the most. In 10 minutes, we will know whether it's giving the person relief. If the person feels relief, we'll continue it. If the person just snatches it away, it's not giving him relief, we'll take it away. I will not want to treat the pulse with the oximeter at this stage. In the operation theater as an anesthetist, I'll be very nervous if there is no pulse oximeter, but for terminal care, I will keep it away. Because if it is there, we start treating it, forgetting the human being. What will help this man are corticosteroids. By reducing the peri-tumor edema, it will open up the airways a little bit. And you and I know that if the airway diameter increases by 1 millimeter, radius increases by only 1 millimeter, flow increases 16 times. And as I said earlier, I would give the person low-dose morphine. And if you think it is illegal not to take the person to ICU and put him on ventilator, or if you think it is illegal to withdraw the ventilator in the face of futility, ladies and gentlemen, let me make this categorical statement. Though India has no law covering this, in the absence of law, a Supreme Court judgment holds valid. The Supreme Court judgment of 2018 acknowledges the importance of withholding and withdrawing artificial life support. They validate it. They validate advanced directives that the person has left. But even if there is no advanced directive, if treatment is considered to be futile by 3 treating doctors together, it is acceptable to withdraw and withhold or withhold life support. Of course, I have been talking about pain and breathlessness and things like that, but we all know that suffering is not only physical, it's also social, issues of relationship. It is emotional, depression, anxiety. It is spiritual. The feeling, why am I alive? I wish I had the strength to kill myself. All that's part of the suffering. And in palliative care, we teach it and we learn it and we practice it. That was not what was taught to me during my MBBS or MD, but now we learn it and we practice it. In palliative care, when we see a patient, what is obvious, what do you think will be obvious? The physical elements of suffering, the pain and symptoms. Whereas many other elements of suffering will come to light when you have taken care of the pain or breathlessness or nausea and vomiting or other symptoms, then the psychosocial issues will surface. And when we probe deep enough, issues related to sexuality or spirituality will come to light. And in our team in Trivandrum, friends, I hope you will visit someday. We have 7 doctors, but we have 13 medical social workers. We have more social workers than doctors because they help us to identify all these problems. One challenge that we will have is the lack of primary care. One of my patients, Geeta is not her real name, but she is very much living in my city of Trivandrum. She actually had lived in this chicken hoop because she had been abandoned by her husband. And she and her 12-year-old son were living here. She had a diabetic foot and was advised amputation. She had been blind for 4 years and they had starved through a weekend. But when we got involved, started looking after them, remember, she was not having a terminal disease in a way. It would have killed her because she could not get treatment. But when we engage the community around us, when we ask for help from through social media, allowed volunteers to get involved, she got her eye operated, retinal surgery, and she saw her son after 4 years. She did not lose her head. She still needs a walker to walk, but she walks. The boy is in school, and our volunteers make sure that not only this boy, but about 300 children of families we care for who have been impoverished get education. And somebody made sure that she has a roof over her head, not in that chicken hoop anymore. So this is a challenge that palliative care workers have to face today in India. We cannot do only things that Bhagyashree does in the USA, where primary care reaches more people. Here, we also have to meet the unmet needs. Sometimes we have to make sure that the diabetes get treated. The antihypertensive medication reaches them. Because without that, dishing out morphine alone will be laughable in our country. The World Health Assembly is the decision-making body of World Health Organization. In 2014, they declared, asked all member countries to integrate palliative care into health systems at all levels, primary, secondary, and tertiary, across the continuum of care, from the beginning of the suffering to the end. This means that the cardiologist, when he sees a patient, is not only looking at the echo or the heart sounds, the person sees the anxiety on the person's face and identifies the element of suffering and addresses it. The ophthalmologist sees not only the eye, but understands anxiety, gives explanations. This integration demands that what Bhagyashree asked for earlier. Every clinician has to lead the fundamentals of palliative care. Do you think that's possible? Or are we talking about impossible objectives? It is happening already. Undergraduate education since 2019, medical education includes palliative care. 6 years from now, doctors will be passing out who understand the principles of palliative care. Hence, friends, I mentioned the value of community participation, but the biggest chunk of contribution to relief from suffering will be with palliative care approach by healthcare providers, everyone. So if you have not learned palliative care, unlike the new medical students, you have not learned it, I have not learned it. So what did I do? I took a course, a short course in palliative care. You could do it too. Even in your evenings, you can do it. Write to us, friends. Just do a virtual course. Learn the fundamentals. I'm sure it'll change your practice. And palliative care unit specialists like Bhagyashree need to see only the selected patients who cannot get adequate relief from suffering from their GP or specialist doctor. Such integration can happen at the level of the national policy. It has already happened. The National Health Policy of 2017 has already included palliative care in primary care. Unfortunately, not in tertiary care yet. Or it can be in the meso level, one hospital, integrating palliative care into all healthcare. For example, Catcher Cancer Center in Silchar, Assam, and Himalayan Institute of Medical Sciences in Dehradun in Uttarakhand are pain-free hospitals. Every single patient coming there is asked, do you have pain? Every doctor and every nurse has undergone a course in pain management, and every patient gets pain relief. Or microscopic level, micro level, it can be one department or one individual. You yourself deciding that in my management, palliative care will be integrated. We are already making a difference. But sorry, I described that already. And I believe a lot is happening. National Program for Palliative Care was created in 2012. I must have admit that it has not done very well. But the amendment to the NDPS Act of 2014 meant that a dramatic improvement has happened in access to opioid medicines. The National Health Policy of 2017 includes palliative care, and MBBS and BSc nursing courses now have palliative care included in them. So I'm hoping that changes will be quick enough for me to get some compassionate relief, compassionate care when my time comes. Thank you, friends. Thank you for listening to me patiently. I stand by for any questions.
Thank you.
Thank you so much, sir, for
Sir,
such a soul-stirring and heart-rending talk. With your kind permission, sir and Bhagyashree madam, can I open the session for discussion?
yes, please.
Good evening, Rajgopal sir. You have enlightened us on so many things, to namely trajectories, ADL, peaceful passing away. Palliative is not mercy killing. Palliative care does not hasten the death. Treatment and palliative is the extra layer. Palliative is the extra layer. Beautiful terminologies. Family satisfaction, and you said bedridden and dementia patients should not die in ICU. And communication, which is the most important part of everything, communication, talking with the family members. Medical poverty, I tell so many times, I was in CCU for 8 years. I tell so many times that you will lose your everything, but patient will not get out of it. So that is the thing which happens in India, especially in dialysis and other parts. Then power of attorney, who decides that. And knowing is not enough, but you have to apply the things also. Advanced care planning. Risk of disease directed therapies. And the last part, which I also face so many times, is unnecessary treatments and procedures.
Yes.
I can mention one thing. 98 years old man
Mm.
has been asked to do the MRI
Wow.
by a physician, and they had called me. His son was an advocate. I know him. He called me and said, sir, you come and see the patient. I had seen him. I said, don't do anything. I don't think he will go for more than 24 hours. And morning, I got the call at 5:30, sir, come please see and see. So if these things happens, that should be stopped, and unnecessary investigations and the procedures should be stopped. Thank you very much, madam. Thank you very much, Rajgopal, sir.
Thank you very much, Bhagyashree madam. अतिशय सुंदर इन्फॉर्मेटिव्ह लेक्चर दिल्याबद्दल. बऱ्याच नवीन गोष्टी आम्हाला पॅलिएटिव्ह मधल्या कळल्या. आणि आय रिक्वेस्ट Rajgopal sir that 2 years back I think you had given some advice of including palliative care in undergraduate curriculum. What can we do about it? In fact, our college dean has also asked us to come to, go to visit your place, Trivandrum there, and do a 3 days workshop. I'm professor in a medical college.
Madam, we have been doing so this is the background so that others also hear this. MBBS curriculum includes palliative care. From the foundation course in the first month of admission to the house residency period, the subjects are spread out. Unfortunately, out of more than 640 medical colleges in the country, only about 40 have people trained in palliative care. So what we are doing, madam, and everybody, is to do faculty development programs. These are both virtual and physical courses. So we did 2 physical courses and we continue to do virtual courses where faculty from medical colleges join us and we, going by the syllabus of the MBBS course, we train people in teaching it. Now, when people have not practiced palliative care, I know this is tough, but at least some kind of education can be imparted. I have put on the chat box the link to our training calendar. So please visit this and consider joining the courses.
She asked, when the patient mentions about living despite serious illness and has no living will, then how to decide on withholding aggressive treatment?
Dr. Priya, do I understand correctly that what you mean is the person wants to live? The person is opting for aggressive life support. Is that it? I actually had a patient with advanced cancer, and she was talking about life support. She said, I don't care what you do. Put me on any life support system, but keep me alive till the 24th because my son is coming home on the 24th. I want him to see me alive, not my dead body. We went by her wish. We put her on a ventilator, trying to satisfy her wish. Unfortunately, she still died on the 23rd. That was sheer bad luck. But the point is, our overriding principle of medical ethics is autonomy. We will respect that person's wish, provided it is not against medical ethics for me to do it. The person says, no, I want to die now. Euthanize me now. I cannot do it. That's illegal and unethical. But within the confines of ethical practice, any aggressive treatment will be given, provided it is affordable and provided it is available, accessible. So the person, there is no compulsion on withdrawing life support. But if it is totally futile, then we will refrain from escalating treatment. Whatever is continuing or started will continue.
I'm the only non-medical person in this group. And I joined just because I was allowed to join. I'm fortunate enough to join just because I'm Bhagyashree's friend. Here, I want to just say one line that whatever discussion I'm listening for last 1 hour, more than 1 hour, is so enlightening that it should go out of medical profession. And every senior citizen must listen to this, educate themselves. Thank you very much. Thank you very much, both.
Barlingay, madam.
Yeah.
Madam. Good evening. Dr. Mohan Patil is here.
Oh, yeah.
Let me admit first that it took little longer time to have this session because my concept, let me admit also, my concept of palliative medicine was not clear. So it took it took little longer time to have this session, and really we people are very much impressed to have this knowledge of palliative medicine. Madam, I'm having one different question apart from this. One of your examples, you told that the brain death patient was he you discontinued his ventilator.
Yes.
You only told in one of first few minutes of your
Yes,
speech
Mhm.
that you discontinued the ventilator of brain death patient. Is
Yeah.
it?
Yes.
Yeah. Did you advocate them to undergo organ transplant at that time?
Yes,
This is
everybody, every patient in
uh,
ICU, they get that
uh,
consultation. Yeah.
yeah. This is a little different question from this topic, but just
No. His
I
organs were donated, and patient's family was very happy about it. Yeah.
thank you, madam.
Dr. Rajgopal was actually, I also joined palliative care since 1992.
Wow.
As he has mentioned in his talk, Shanti Avedana Ashram, I was a very young anesthesiologist at that time. I visited Shanti Avedana Ashram and I took inspiration from that. And I started palliative care in Pune since 1992. And still I am practicing, and I am now teaching my students in medical college here about the palliative care.
All right.
So
Very
we are providing that. Thank you, madam. Thank you. Nice talks. Both of you covered very well and very inspiring. And as you have mentioned that all senior citizens also should listen to this. This is very, very important. Thank you.
Thank you.
So, sir, recently we had gone on a home visit, and there was a 92-year-old patient with CA lung, and his main complaint was pain. So, and he had, it was an advanced CA with meds. So I had started him on the minimal dose of morphine. But when I gave the morphine to the family members, at that time only they were a bit skeptical, saying that this is a drug, won't he get addicted to it? So I assured them that that will not be so. But the next day when we rang them up, they said that the patient had respiratory difficulty, and he was feeling hot and cold alternately. And then they had to admit the patient in some institute, in a hospital, where they were told that it could be due to morphine. So, sir, what to do in such situations?
No, Dr. Manisha, this is not infrequent at all. In the early days, very sincere doctors truly believe that morphine, one dose of morphine one tablet of morphine will cause respiratory depression and kill them. So this fear is widespread. And early days of our work, we had to face a lot of this alone. Even now, it is still there among, if there is a doctor in the family, then it's very difficult to get morphine across to that family. One of my professors, 3 of my professors died in the last month, but one of them died in pain, hands and feet tied, because they did not want her to pull out the nasogastric tube. So the fear is there, Dr. Manisha. We can only keep on educating people. And one of the most effective things that I have found is people who are on morphine talking to others on morphine. And when people talk and say, I am taking this tablet and I am still functioning, that seems to work better than we professionals talking about it. But I'm sorry to see that you have these difficulties. But to everybody in the early days, before awareness, this is pretty much the routine.
I'm Dr. Sushma Malik. Heartiest congratulations to both of you. It's been such an enlightening session. And I must admit that I have been into palliative care only for the last 7-8 years. And you can call it as ignorance or whatever. First time I heard of neonatal palliative care was about 8 years back. And I was heading pediatric department as well as neonatology. So with the help of Dr. Armida Fernandez, so last year we opened up our palliative care, pediatric palliative care, inclusive of neonatology also, for non-cancer patients primarily. Sir, I want to know that what about neonatal palliative care? We've also started palliative care at KEM Hospital in Mumbai. And it's a very new concept. People don't even know about pediatric palliative care. There are lots of myths. In my own hospital, in my own department, we have had to struggle with our admin people, but we've started it, sir. And I need your blessings to still continue, sir. And please tell us a little more on neonatal care, palliative care, sir, if time permits, if I can ask for 2-3 minutes from y'all.
Dr. Sushma,
Yes, sir.
you can teach us all. If I speak about neonatal palliative care, it will be a little bookish from the tiny little bit I have read about it. You have walked the talk. You know.
Yes.
Please tell us.
Yes,
like it is very sad sometimes when we see neonates who have zero hope of recovery.
Absolutely, sir.
And going through those tiny things are subjected to so much of
absolutely, sir.
Yeah.
I have seen parents on extremes, somebody says you just take about the ventilator, and our admin at our own hospital and all major hospitals, they do not allow us to disconnect the ventilator. When we know that the patient is brain dead, yet they don't allow us. They won't give us the ambulance to take them home. They say it's against the law. Where is the law? Why aren't you writing? Our own ethics committee would first question us, sir. And then we were still in the stage of forming, but I'm very much interested in this. We are looking out for laws. Ruchi Nanavati and myself, along with Dr. Fernandez, we are trying hard to get, as you said, I heard today from you that we have the Supreme Court's verdict that you can withdraw a ventilator. That was so heartening for me to learn this, and I'm going to definitely read it up, and I want to teach my juniors and learn first myself of how we can proceed. There are lots of barriers, sir, and the first barrier is the ignorance, sir. People are not even aware. People think it's only for cancer. There are no non-cancer, palliative care. What is home care? We are still absolutely, as you said, at the tip of the iceberg where there's so much of a problem.
Dr. Sushma, I hope, especially about that Supreme Court judgment and the problems there and the positives and the negatives. I would very much like to discuss more with you. I put up my email ID on the chat box for anyone to write. Please write to me. But Bhagya, this brings up a very important point. Now that we are doing all these webinars in Maharashtra, I am sure we need to have one on end-of-life care, including the legal and ethical aspects of it.
Absolutely, sir. Absolutely.
Dr. Sushma and everybody, I have just now put up a link on the chat box to talk to your ethics committee or to anybody who tells you that it is illegal to withhold ventilator. Please look at these guidelines. This is from Indian Society of Critical Care Medicine. And it quotes the law. It quotes not the law. We don't have a law. The Supreme Court judgment, the catches there and the way out and how to go about it.
Definitely, sir. Definitely, sir.